Hey, I want to welcome everybody to a Compass to MS Care event. We are in Louisville, Kentucky today, and we have some people here in attendance, as well as we are doing this program live, as you do know. So today's guest speaker, we have Dr. Aaron Boster, and Dr. Aaron Boster will be speaking about MS symptom management, understanding new and future MS treatments, stem cell therapy updates, access to MS care and managed needs, and health and wellness during COVID-19. For everybody to know, this is an MS Views and News program, and today we have exhibit sponsors. We have people exhibiting outside in the hallway, and they are here in the room as well. And this is from Alexion, Novartis, Bristol-Myers Squibb, and TG Therapeutics. Some of these names are brand new to the environment, so if you don't recognize them, you will be hearing more and more about them over the next few months. They're going to start doing a lot of programs, patient programs. They're going to have speakers such as Dr. Boster and many other doctors around the country and nurse practitioners that you do already know about. But you will be hearing more about those different medications that are soon available or are coming available as we speak, okay? So, again, today's topics I just listed, and we are going to be listening to Dr. Boster for about 30 to 35 minutes, and then we're going to turn it over to Q&A. For everybody that's online, the usual, okay? Type in your questions, whatever questions you might have, and I'll go back and forth between the room and my laptop to get your questions of what you type in. And where do you find it if you've not been there yet? Is go to the top of the scroll on the right side of the screen, and you find the red or the orange box. Click on that. Type in your question and just wait for me to get to it. We will get to all questions, okay? So also for everybody in the room, if you have a question, please raise your hand. Let me acknowledge you, and I will get back to you. Remember, I can put the microphone up towards your mouth only if you're wearing a mask, all right? So if you're not wearing a mask and you have a question, you're going to have to call it out to me, and I'll have to call it into the microphone, all right? Thank you very much. Let's get this program started. Let's welcome Dr. Boster from the Boster MS Center in Columbus, Ohio. Welcome.
Thanks for having me. Howdy. Some of you have not heard me lecture before, and you don't know the audience participation. It works like this. I'm going to give a call, and then you're going to give a response. My call is howdy, and your call can be the exact same. Ready? On the count of 3. 1, 2, 3. Howdy! Howdy! That's a lot better. Thank you very much for having me. I want to thank Stuart. I want to thank MS Views and News for this opportunity. I also want to thank each and every one of you who took time out of your day to come visit me live. It's an honor and a privilege to get to see real live human beings in person during a global viral pandemic. I also want to say hello to the folks in the interwebs out there. I'm really, really happy that all of you can join me and I can talk to you a little bit about upping your game in the setting of multiple sclerosis. Stuart asked me to list a couple different topics today, right? So he rattled off a couple things that he wants us to talk about. And I've spent the last couple days kind of processing them, and I've put them into a format that I hope resonates with you. So maybe at the end of the talk, you can let me know how it goes. This will be the first time I kind of give this discussion live. And I've titled the talk, We Don't Treat MS Correctly. That's the title of the talk. We don't treat MS correctly. 2021, we don't take care of MS the way I think it should be. And by the way, who's we? We is me. We as clinicians, MS specialists, doctors, and nurse practitioners alike. Oh, it's okay. That sounds like DEFCON 5. Like, ooh, ooh. So that's what I want to frame our discussion talking about today. And as we talk about how we don't treat MS correctly, I then want to share with you some thoughts I have on how we might correct those wrongs. Now, I'm going to separate my thoughts into 3 categories. I want to talk about the use of disease-modifying therapies to slow down MS and how we're not using them properly. I want to talk about where and when and how we physically see people impacted by MS and how we've been doing that wrong. And lastly, I want to talk about how, in my opinion, ignoring quality of life and ignoring chronic symptoms is not the right thing to be doing. All right, so that's the lecture. So let's jump in and talk about how we're not doing things right. By the way, if you have a question and you can't wait till the end, I don't mind. Just raise your hand and we can talk while we're going along. Disease-modifying therapies is an encompassed term for drugs that slow down multiple sclerosis, right? So we're not talking about drugs to treat a symptom like an ache or a pain, but a drug that actually makes the disease slow down, right? The very first MS disease-modifying therapy came out in 1993. My uncle was already fixed in a wheelchair in 1993. We weren't lucky enough to win the lottery in 1993, and he wasn't given the opportunity to be on beta-seron. I stand before you today with his memory in my heart, with 25 different formulations of FDA-approved medications that I can offer you and your family to up your game and slow the disease down. I am very passionate about making options available to you and your family. And when you think, oh gosh, gee, Aaron, that's awesome. There's 25 different medicines. We have all these different things that we can do. I lament that we don't use them properly. And it really goes back to a concept that I will call sins of our fathers. What is this little balding guy talking about? Sins of our fathers, I say. The men who taught me multiple sclerosis, my professors, come from an era where they didn't have treatments. Those are the guys that took care of my uncle. They remember when there were no therapies available to treat MS. So in the early 90s, when the first therapies came out, that was a proper revolution. That was truly transformative to go from nothing to something. And these men and women, these early therapeutic adventurers in MS, started to use these medicines. And for the next 15 years, the medicines didn't really change. We came out with a lot of shots, a lot of interferon products, glutaric acetate, etc. And it wasn't until about 2010 that the first new medicine that wasn't one of those Me Too drugs came out. 2010, there was a drug called Gilenya that came out. It was the first pill. It was also, in my opinion, one of the first highly effective drugs, aside from Tysabri. And what happened subsequent to that time period, all of these drugs that tend to be more effective and more scary with more side effects and complexity came out on the market. And it's my opinion that the men that adopted those first therapies 15 years later have grown tired, or dare I say, maybe a little lazy. And they were disinclined to adopt the complexities of these new therapies, to take on the risk of these new therapies. And those were the men that taught me. So when I went into clinical practice, I did what I was taught, and I used an escalation model to treat my patients. And I apologize for that because it's not the right way to do things. Show of hands if you're familiar with an escalation model. Ever heard of that? A couple people have. So the escalation model is a style of treatment. Now, not style like, wow, Aaron, that's a nice suit. I mean style like the order in which you place medicines. Like, so the style in which you do that. And so the most common style in the world to treat MS is an escalation style. It goes like this. You have MS, and I'm a good doctor. I'm going to put you on a very low efficacy drug, which is very safe. So we're very, very unlikely to have side effects. And we'll see what happens. And if you do great, then I am a great doctor, and you are a great patient, and that is a great drug, and we'll just keep on keeping on. But if something doesn't go well, don't worry about it. That's okay, because I'll pick it up because I'm a great doctor, and I'll change your drug, and we'll just go on to something that's a bit better, but maybe less pleasant side effects. And then we'll just see how things go. And if that second drug works great for you, then I'm a great doctor, and you're a great patient. That's a great drug, and we'll just keep on doing that. And if it doesn't work out, don't worry. I'm going to catch it because I'm a good doctor, and I'm going to escalate your drug to something that works better. That's the escalation model. That's the concept. And it's intended to be the perfect balance between risk and benefit, and that's hogwash. That's false. It's incorrect. Allow me to explain. When I say we'll escalate if it doesn't work out, what does doesn't work out mean? What does it mean when it doesn't work out? It means that you have an attack. It means that you have a new spot. What is an attack or a new spot? It's brain damage. Did you know that? When you have a new spot on your MRI, I'm showing you damage to the holiest of holies, the supercomputer that runs the whole body, the brain. And the superhighway, the spinal cord that takes all the information from the supercomputer down to my boots and back up. And so it's nonsensical that I have to allow you to accrue irreversible brain damage before I'm allowed to put you on a drug that might work better, my opinion. Now, it doesn't make me right, it just makes me opinionated, but you're being really polite and letting me talk, so I'm going to keep on keeping on. If you think about the escalation model, remember how I told you, don't worry, I'll catch it if something goes wrong? Remember I told you I'm a good doctor, don't worry? What if I can't catch it? What if you forget to tell me that 3 months ago you were dragging your leg for a week and it got better? Not on purpose, you just forgot. What if I'm busy and I forgot to ask you about your bladder? And you are uncomfortable sharing that you're incontinent of urine, and we just skip that part? What if the MRI is not perfect and it doesn't catch all the stuff? What if I can't give you back what you lost? If you have 3 children and start birth control, you have 3 children. You take birth control all day, every day, you still have 3 children. And if you want to know why you're on birth control, go hang out with your 3 children. You're on birth control because you don't want an unplanned event. The brain damage that you've accrued, I can't give back to you. And I hate that, honestly, but it's true. And so I need to do everything I can to bring a SWAT team to a knife fight. I'm not going to bring a knife to a knife fight. I'm 5'6", $160. I don't know how to fight. I'm not going to hold a knife. I'll get cut. I'm going to have 4 guys in front of me that look like G.I. Joe with muscles on their muscles and flak jackets and semi-automatic weapons, and I'm going to stand like this with my hand up in the air and a particular finger raised as I fight MS. That's what I want to do. I want to put you on the most effective drug that you're comfortable taking. Now that is a very important sentence that I crafted. I want you on the most effective drug that you're comfortable taking. And that doesn't mean that it's the most effective drug that exists, because you might not feel okay with that. There's a nice gal over here, and when I was going around the room saying hello, howdy, I, she asked me an outstanding question. She says, what happens when a patient doesn't agree with you about therapy? What'd I tell you? I said, that's okay. I said, you're in charge of you. You're a you expert. You know all about you, way more than even your spouse, right? And you're in charge of you, and it's your body, and it's your brain, and it's your insurance money, right? It's your life. I'm not smarter than you. I just read books you didn't read, right? But you're a you expert, so if we get together, we're a team to be reckoned with, right? MS doesn't stand a chance. And what we have to do is I have to educate you about the stuff I read about, and I have to listen to what you want to do in life, and then we have to try to find the most effective drug that you're okay with. Make sense? The escalation model is flawed, and you can end up neurologically disabled at the time you get on a really effective medicine that would have been awesome given to you earlier. And that doesn't sit well with me. We have removed the escalation model from other fields that are farther along than mine. Oncology. You wouldn't take the 5th best drug available for your lung cancer, would you? See how it goes. If it doesn't work, then take the 4th best drug. See how it goes. If it doesn't work, take the 3rd best drug. Whoops, now you don't have any lungs left. They don't do that in oncology. They come out of the box swinging. And we can do the same thing. Remember how I said I wasn't just going to tell you what I didn't like, I was going to tell you how I thought we might fix it? Now there's that part. So as it relates to disease-modifying therapy, I think that there are 2 styles of treatment that are superior to escalation. The first style is the opposite of escalation, which is called induction. Induction is what they do with cancer. They diagnose you with cancer and they set off a nuclear bomb. Sometimes they give you 3 or 4 heavy-hitting chemotherapeutic agents or a stem cell transplant, and they clear the cancer, and then they put you on a maintenance drug to keep it away. That's actually very effective. Do you know that they do the same thing with rheumatology? Oftentimes, they'll stack heavy-hitting drugs up front because it works better than if they do it later. Did you know that's how we fixed AIDS? We fixed AIDS not by developing drugs, but by stacking them all up front with multiple antiretrovirals up front and then a maintenance afterwards. I think it's high time that people impacted by MS can benefit from the same learnings of those fields. And so induction therapy is a style of therapy where you don't start on the lowest efficacy medicine. You start on not just a high efficacy medicine, but something that reboots your immune system, right? So a stem cell transplantation is an example of induction therapy. Alemtuzumab, codenamed for Lemtrada, is an example of induction therapy. There are many different induction styles of therapy. There's a pill called Mavenclad that I refer to as microinduction. Off-label, there's drugs like Cytoxan. My point is, we have an armamentarium to hit it hard up front and then to maintain over. All right? And that doesn't mean that's the only way that we can treat MS. It's just a smarter way than the escalation model. Let me present a second model. It's called, let's use the most effective medicine up front. Right? It's called early, highly effective medicine. So instead of starting with an injection that came out in the 90s, we might start with an infusion in the vein or a high efficacy pill early on in the disease process. And it's my hope that as we move forward in time that my colleagues around the world can move away from this flawed escalation model and use the drugs that are currently available and currently being developed in a smarter manner to help you live a better life. It's all about allowing you to have a brain that ages naturally. That's all we're trying to do. I want you to be bored in my clinic, and I want you to be excited in the bedroom and in the boardroom and on the playing field and in other aspects of life, because I want to make your MS boring. And applying an excellent MS medicine too late is a missed opportunity. Now, it's not just using the most effective medicines you're comfortable with up front. There's another problem with the way that we use medicines. I'm going to share with you a research study. There's a drug called Tysabri, a highly effective drug. It's an infusion in the vein. It's one of the most effective drugs on the market, I think. And there was a study done in Germany where they looked at a bunch of people on Tysabri for a long period of time. And what they found was 25%, so a quarter of all those Tysabri patients were not having attacks. Nope. They weren't having new spots on their MRI. Nope. And they were progressing on their exam. They were getting worse neurologically. So that's called progression independent from relapse activity, PIRA. Progression independent from relapse activity. It's not unique to Tysabri. It happens with all drugs. It's just that doctors like myself are starting to wake up and pay attention to it. And my point here is these drugs that we have are anti-inflammatory agents, and they're really potent and they work really good up front. But we need desperately to develop another therapeutic arm, which can work on the smoldering, burning, in the background MS, which is eroding things and causing the progression that we see increasingly as we move forward in the disease process. I stand before you very, very excited to be an MS researcher. A good portion of my career has been helping develop MS Therapeutics, and at the Boster Center for MS, we're running multiple MS clinical trials right now. Why? Because I'm trying to help develop that next thing. And I'll share with you very briefly something that I think is very exciting. And so is that salad. Now, we're studying a molecule called BTK inhibitor. BTK, butyrate tyrosine kinase inhibitor. They're a little pill. Boom. They've been approved and used in cancers, and it turns out they look really, really exciting in MS. And where I think they're going to be the most exciting is not treating relapses, it's slowing disability. Where I think they're going to be most excited is not quelling GAD, but slowing brain volume loss. And the future is very, very bright. And so as I talk to you about the fact that we don't do MS correctly, my first point is that I don't think we use disease-modifying therapies correctly. And I think moving away from an escalation model to an induction or early high-efficacy model makes a lot more sense. That's the first of three things that I wanted to talk to you about today. The second, as it relates to we don't do things right in MS, is where, how, and when we see patients. What do I mean by that? Where do we see patients? Well, where do you see patients? You see patients at the doctor's office or in the hospital. When do you see patients? You see patients when the doctor tells you he will see you. How do you see patients? We make them come to the waiting room and we bring them in a room and they sit there until the doctor has time, and then he comes in and does some things and then he leaves. And then the patient waits there until someone tells them they can go home. Guys, that doesn't make a lot of sense, does it? We learned something starting in March of 2020. We learned a lot of things. One of the things we learned is you don't have to come into work to work. The entire chronic disease community, millions of Americans have been demanding telehealth and telemedicine for decades. People impacted by MS and their families have been demanding telemedicine for decades. And nobody listened until there was a global viral pandemic and a bunch of otherwise healthy people really needed access to their doctors. Okay. But I sincerely hope that we have learned a lot, and that if there's a take-home, if there's a silver lining from this abysmal global viral pandemic that we're now 2 years into, it might be telehealth. It might actually be telehealth. Let me give you a couple examples. I have the privilege of taking care of a gentleman who's in his late 30s, and he has absolutely devastating multiple sclerosis. He can't come to a visit like this because he lives in a bed in a nursing facility, and he can't sit up or roll over on his own. He's really, really affected. Now, when he comes to see me in clinic, traditionally the old school way, he had to rent an ambulance at a cost to his family, a rather high cost. They had to take him in a bed out of his home, jostled about, put into the back of a van. He was strapped into a van and he traveled an hour and a half on the Ohio highways to get to my clinic, where then some burly guys would unload him and bring him through the doors of the clinic, bumping and smacking into things until he finally ended up in a room, exhausted and frustrated and confused. And then I would come in and I would see him. And if I had a question for his family, well, they were there because he was brought by an ambulance and they weren't allowed to come with the ambulance. Let's fast forward to a couple months ago. I got to see the same gentleman. He didn't get in an ambulance. He didn't travel an hour and a half. He simply turned on his camera. And there he was with his family in his bedroom where he lived, comfortable, smiling. And we had a very, very engaged discussion. His family was there. When I needed to look at a certain part of his body, they would put it in front of the camera so I could ask him to do things. I really felt like I was able to properly understand the situation. He was not inconvenienced. And when the visit ended, he turned off the camera and he was back home. Is that not better? Is that not better? Let me give you a different example. Let's pretend that we identify that you're having a problem with your bladder. And sometimes you can't make it in time and you may have a potty accident. Now, very few things upsets humans more than that, particularly adult humans. 3-year-olds, not so much. And let's say that during the course of the clinic visit, we're going to start you on a little pill, all right, you take every morning, and we're going to see what it does to your bladder. In the old school traditional way of doing things, you're allowed to tell me about it 6 months later when you come back to see me. Or you can call and try to talk to my nurse, and I'll eventually get a message maybe. But in the modern era with telemedicine, what I do today, I feel seems better to me. I will see you for a 15-minute quick telemedicine visit in a month or in 3 weeks, where I can touch base and say, hey, I put you on that pill. Were you able to get it? No? What's wrong? There's an insurance problem, then I can work on that. Or you're taking it? Do you have side effects? Uh-oh, you have side effects. Let's make a switcheroo. But if you're taking it and not having side effects, I can ask you the important question, is it working? And based on that answer, I can adjust the medicine, and now we're good in the hood. Isn't that a better way to manage a medicine for a chronic condition? All of you are chewing, and I assume that you're saying, through your bites of salad. I'm enjoying watching you and smelling you eat, by the way. We don't do MS correctly, and it goes beyond the way that we see patients in clinic. I like to see my patients every 3 months. That's my preference, to see people every 3 months. And that's twice as much as the national average. But before I dust my shoulders off and tell you how cool I am, think about what I just said. If I see you 4 days out of the year, that means that 361 days out of the year, you still have MS and I'm nowhere near you. How am I going to teach you to up your game if I only see you for 4 days a year? If I was going to teach you my favorite game, chess, and we got together for a half an hour every 3 months, you would stink at chess. You wouldn't be very good at chess because that's not enough time for me to teach you the game of chess. In essence, when we meet, I'm trying to teach you how to up your game and beat the pants off MS to let your brain age naturally and so that you live your life more fully. How am I supposed to do that if I only see you for half an hour? We spend half the time like doing this kind of stuff. Well, there are ways to do that. And right now, all of you that are listening to me are participating in that process. You are upping your game and learning how to be a self-advocate and learning knowledge so that you can take care of your disease better and you're not in clinic. That makes a lot of sense to me. What makes even more sense, arguably, is what the people on camera are doing. Because there are people right now listening in to this hybrid program. But today is December 2021, and somebody listening is listening in the future. They're listening to this after the fact. Maybe they're listening at 3 in the morning in their bathroom by themselves. That's when they need to hear this. That's when they need to hear the information because that's the right time for them. Your doctor's probably not going to take your phone call and answer your question at 3 in the morning. But YouTube is ever present. And MS Views and News has an amazing channel, a web channel, a repository of the who's who in MS teaching their subfields. It's brilliant, and it's available to you on demand. And I think that makes more sense for upping your game. I've worked in healthcare systems where I helped develop exercise programs where we would jazzercise together and get together in group classes, and I really felt very proud about it. I loved it. And all that died with the pandemic. I'm really excited that we are about to launch a program at my center. It's a virtual exercise program. It's a retail program, $19.95. You get 2 to 3 exercise sessions with a MS specialized trainer on camera where they can see you and you can see them, and you can put on your Lululemon right in your living room and you can do your groove thing, and then you can watch it on demand. Now, do I think that's the very best thing in the universe? I'm pretty excited about it. Are there other options? Absolutely. What's the point? The point is we're all trying to create options to game out how to keep you fit and stay active despite the fact that I can't ask you to go to the gym right now. My second point, as we discuss why we don't do MS correctly, is that when we see people should be on your time, not mine. Where we see people should be based on what we're trying to accomplish. If I'm going to go over an MRI with you, I would rather you be at home on your camera because then I don't expose you to infections at my clinic. And I can have a very engaged conversation showing you the pictures on screen. The second point that I'm trying to make is that we don't take care of MS patients in the right location at the right time. And I think that we have the wherewithal because of telemedicine and because of virtual activities to really change that for the better. Now, I told you when I came up here that there were 3 things that I had a bone to pick about how we don't take care of MS properly. I said the first one was the way that we use disease-modifying therapies, leveraging the escalation model when we should be using induction or highly effective drugs up front. The second thing really was an issue I have with how we see patients and how telemedicine has taught me that we can do it better and we can do it different. But the third area I really think we need to improve upon is we need to stop ignoring chronic symptoms. We need to focus on quality of life. So let me explain to you. If I give you an MS disease-modifying therapy and it works, and your disease is slower, and you're miserable in the process, I didn't do my best job, did I? If I want to go home at night and look at my kids and say, Max and Betty, today I did a good job, I need to do 2 things in clinic. I need to slow your disease down and I need to raise your quality of life. I need to improve your quality of life. How do I improve your quality of life? I treat chronic symptoms. We were talking about bladder before. If you are a 55-year-old gal and you pee your pants at the supermarket, it is a bad day. It's a bad day. And I have a pill for that ill. But if I don't have the foresight to ask you, darling, are you having any trouble with the bowel, the bladder, sexual function? You might not feel comfortable sharing it with me. And you may languish for another 3 months, wetting yourself when you don't want to, or avoiding water and making yourself dehydrated and making your symptoms worse because we're not communicating. So we need to do a better job of identifying and addressing chronic symptoms. In specific, I really want to focus my attention on invisible symptoms. Who here has heard about invisible symptoms in MS? So not everyone around the table, or maybe some people are just very engrossed with their salads, which I understand. Many symptoms in MS are invisible to the outside observer. Many of you have heard, I didn't know that you were sick. Well, honey, you look so good. Well, you must be getting better, yeah? Well, I didn't know that you looked ill-informed and stupid. But you are. I'm teasing. My point here is that we need to do a better job of looking for invisible symptoms. And I summarize most of the invisible symptoms that I care about, talking about the up there's and the down there's. So what are the up there's? You know, the up there's, thinking of memory, energy, and mood, the triad. Very common that people impacted by MS experience fatigue. Whew! In fact, it's the leading cause of loss of work. The leading cause of loss of work for people with MS is they're so tired they can't function in the workplace. That's a travesty. In fact, 50% of people leave the workforce within 10 years because of that. That's a really big deal. Fatigue is a really big deal. But honey, you look fine. And when you tell your coworker, child, spouse, boss that you're tired, what do they say? Yeah, me too. Except they have no idea what they mean when they say me too. Here's the best example I've ever come up with trying to explain to a spouse what MS fatigue is like. You guys in the room who know better than I, you can correct me. Imagine that on Monday you went to work, came home, ate dinner with your family, then don't go to bed. Go to my YouTube channel and watch half the YouTube videos. Stay up all night long. Get up in the morning, shower so you're not stinky, go to work, come home, eat dinner with your family. And the second night, don't go to bed, finish watching my YouTube videos. Come on, there's 450 of them. Wednesday morning, we're going to go for a walk and talk about MS fatigue. It's a kind of fatigue that's sometimes hard for spouses to understand. That's one of the three up there's, and you can't see it just to look at someone because, honey, you look so good. Same thing with mood. People impacted by MS are twice as likely to experience anxiety compared to the general population. People impacted by MS are twice as likely to experience a bout of depression compared to the general population. Now, wait a second, guys. People with MS are twice as likely to experience depression. There's a global viral pandemic, which has caused a mental health crisis and removed all community resources. And you're telling me, no, Dr. Boster, I'm fine. Nuh-uh. Thinking and memory is another one of those up there's, the triad. Thinking and memory is something that impacts between 50 and 70% of people with MS. Now, it's not an Alzheimer's dementia where you're not sure who you are, where those kind of things. It's trouble with multitasking. It's trouble with remembering. It's trouble with working under pressure. It's trouble keeping a list active in your head. It's that kind of stuff, and it's extremely frustrating. And the outside observer just thinks that you're not attentive, like you're not paying attention, except you are. You're trying really, really hard. Well, maybe you're just not caring as much as you used to. That's not it. So thinking and memory, energy and mood are the up there's. And it's my opinion that I need to be proactively asking you with every single visit, how are we doing? Now, can I tell you, one of the ways I do that is I send you a virtual form. So I have a fancy pants electronic medical record, and if you're logged on to the patient portal before your visit, I can dispatch some questionnaires. Those questionnaires are very important to me because it captures your voice. It tells me how you've been doing the last couple of months. It tells me about your pain. It tells me about your energy and your anxiety and your depression and your sleep patterns and your working and your smoking cigarettes and your vaccinations. And I have all this information that's provided for me before I see you. And that informs our discussion to make it more effective. Because if you tell me that your bladder is good in the hood, I'm not going to ask you if your bladder is okay, because you already told me. And if you tell me that you're depressed, I may start our discussion dealing with depression. I just think that's a better way to do things. Now, I said that when we're talking about invisible symptoms, we have to talk about the up there's, thinking of memory, energy, and mood, and the down there's. You know the down there's, bowel, bladder, and sexual function, or as I like to say in mixed company, bowel, bladder, and bedroom. Because if you would like to make an adult human upset, make them incontinent of urine or stool, or make them have difficulties in the bedroom. And you will find an adult human who is really unhappy with their quality of life. And not only are those topics not visible to the outside observer, they're also, in some cultures, a bit taboo. And so people may not be comfortable sharing with their clinician that they had a potty accident. I respect that. And yet, to ignore that is to allow someone to have a plummeting quality of life. And so what I recommend, again, is that with every single visit, I'm asking you, any problems with erectile function? Any difficulties with bowels? Any constipation? How are we doing? And what I'm trying to do, in fact, is to normalize that discussion, because I want you to feel comfortable sharing that with me so I can up your game and help you live your best life. In 2021, we don't take care of MS correctly, but we have the capacity to improve MS treaters. I don't think that we use disease-modifying therapies the way that we should. I think we need to use the most effective drug you're comfortable with up front, and I think we need to continue to develop drugs for the second half of the disease. I don't think we see patients in the right location at the right time because we pick when we want to see you for how long and in what capacity. You're welcome. No, guys. It needs to be the other way around. We need to see you when you need to be seen, in a way that you need to be seen, in a way that is convenient for you, not me. It's your body and your brain. I think we can leverage telemedicine and virtual education as a massive way to improve that situation. I really do. I think we're actually doing that now in some cases. Lastly, I think that we need to do a better job dealing with chronic symptoms to up people's games and help them live their best life despite having MS and remove invisible symptoms. You guys have been fantastically interactive today, and I want to thank you for that. I'm going to wrap up the didactic right now. We're going to open some things up to questions. Now, these are both questions online and in the audience. So if you're in the audience, remember, just raise your hand. Stuart from MSD's News will come over to you. Please have your mask on so you can speak into it without spitting. Ask your question, and please make sure that your question is a generalized question, because I can't give you specific information about you because I don't have enough info as we talk right now. We're going to bounce back and forth between some questions in the audience live and also the folks that are on the interwebs. And so let's kick it off. Stuart?
I am so glad that I have Dr. Boster to fill in for me while I'm out of the room. Thank you very much, and let's give Dr. Boster a round of applause, all right? Does anybody out here have questions? Okay, great. Let's start with everybody out here first. Then we'll get to those that are online, all right? That's right, you're first. That's right.
I love being first. I have two.
Okay, go.
Okay. First question: if you start with the powerful drugs, like you were saying, and like what if is there nowhere to go afterwards if those stop working?
That's a very good question. So the question was, if you use the highly effective medicines up front model as opposed to an escalation model, what happens if you put them on one of those and it doesn't work? Are you stuck? No, fortunately, because there are several highly effective medicines. I would say out of 25 medicines, 5 to 8 of them are rock stars. That's 5 to 8. And so if I put you on one highly effective medicine and it's not working out, we better identify that. We can make a lateral move to something that's also awesome and still keep your disease at bay. We don't have to de-escalate at that point.
Cool. Okay, and then the second question is, as a person with MS, like during the cold and flu season, can you super hype up on vitamin C and amp up your immune system, or is that not advisable in general? And when I say super amp up, I mean like mega doses of awesome vitamin C, because I used to love to take it, but I don't take it anymore.
So the question was, if you're concerned about flu and cold season with MS, could you really overdose yourself on high levels of vitamin C and protect yourself? Yes, you can overdose, but it won't protect you. And so there's a very scant data about vitamin C and E helping when you first have the flu, but I don't think that would be effective. And I would not recommend that, certainly not outside supervision from a doc. You know what does work better? Honestly, it's almost foolproof. No, let's see, it's this. So did you know last year when millions of human beings were trying to sequester to avoid COVID, we didn't have a flu season? Flu drugs plummeted in their stocks because people wore masks and stayed out of the fray. And so, in fact, if we used this smart behavior during the winter, you would decrease your risk of flu. I will share something that I'm a little bit embarrassed about, so that's fun because it's public. I used to fly a lot. Like pre-pandemic, I traveled quite a bit. And I always would kind of giggle to myself, never out loud, but I would kind of laugh in my head when I saw an Asian business person wearing a mask. Someone that's flying from Japan and they're wearing a mask on the plane. I thought, oh, that's weird. Why is he bothering wearing a mask? Well, I want to formally apologize because he was right and I was wrong. And he was being safe, not just for himself, but for me. And I've learned a scary lesson. And so I will continue to wear a mask in the winters, even when the pandemic's over, because I don't like to get the flu. Good question.
Back here.
Something you didn't talk about, but I'm curious about the current thinking of lifespan and the
DMTs?
the possibility of people shortening their life expectancy because of MS.
Okay. So the question is related to life expectancy and multiple sclerosis. Like, in other words, if you have MS, you're going to die early, if I may be a little blunt. Now, when we studied this before, we found that people impacted by MS untreated have a shorter lifespan by about 7 years compared to the general population. It's my strong belief that with the earliest application of highly effective medicines, we're continuing that. We're actually extending life. And I want to give you an eerie example. Remember how when I started talking today, I made reference to the early 90s when the medicines first came out? The very first medicine to come out was a drug, and still out there today, called beta-seron. Right? Beta-seron is an injection that you take thrice weekly. And the first trial where we studied beta-seron was called the BENEFIT trial. And so people with MS entered this trial, and they either went on placebo, dummy drug, or beta-seron for 2 years. And then at the end of 2 years, they all went on beta-seron. And many of those patients have been followed for 20 years. They've been followed in a long-term cohort for 20 years. That's amazing. And 2 years ago or 3 years ago, a friend of mine published a very eerie paper, a guy named Tody Reeder. And what he showed in his paper was The group of people that started on beta-seron right away were living longer than the people that waited 2 years. And it was highly statistically significant. I one time had someone in clinic say, give me one reason to take your drug. And I said, it'll make you live longer. And so he said, okay. So I think that by identifying MS as early as we can and starting on the most effective medicine and trying to allow your brain to age naturally, we're prolonging life in the setting of MS. Excellent question. Thank you.
Okay, next question. All right, I'll be over to you in a little bit. I want to take some that are coming in online. First off, there's a Christine asking or saying, I completely agree with your opinion on induction therapy and using the most effective therapy up front. However, despite advocacy efforts in step therapy legislation, patients and care providers still face barriers with insurance enforcing step therapy with MS medications. How do you combat those?
So I didn't pay Christine to ask that question, but I coulda, because it's a real good question. What Christine is talking about is something called systemic therapeutic inertia. Show of hands if you've ever heard of therapeutic inertia. Show of hands if you're familiar with the physics term inertia. All right, so inertia states that an object at rest will stay at rest. Like, so if you have a giant boulder that's just sitting there, it's probably not going to move. And an object in motion is likely to stay in motion. So if you roll the boulder down the hill, it's going to probably just keep rolling for a while. That's inertia. Therapeutic inertia is a term that was coined in the 80s in the cardiovascular literature, where they would identify someone that had high blood pressure. And they'd put them on a medicine, and a couple months later, they'd recheck the blood pressure. It was still high, and they didn't change. There was an inertia of therapy. There was identification of need for change, except they didn't. That's therapeutic inertia. Therapeutic inertia, in my opinion, is the leading cause of loss of work amongst people with MS, because it's resulting in people not getting escalation of therapy when they need it. Now, there are 3 groups of people that participate in therapeutic inertia. Patients can participate in their own therapeutic inertia by not being forthcoming about what's going on, so that I don't know that you're failing something and not doing well and I need to make a change. But you are not the worst actor, not at all. I don't want to suggest that even a little bit. The second group are actually doctors. We contribute to therapeutic inertia by not being good listeners and not considering the ramifications of what we're doing all the time. But the question that Christine asks really touches on the third group of people participating in therapeutic inertia. And that's the system that we practice medicine in. Most of us pay for our therapies and our drugs and whatnot through an insurance payer, so a third-party insurance. And that insurance can make up rules like, you're required to fail this drug before I'll give you access to that drug. And this drug is not as good as that drug. That's called a step edit. That's what she was talking about. And that is a form of therapeutic inertia. So what can we possibly do? Well, I'll tell you what I do every single day. Every single day I fight. Every single day my team writes letters to insurance companies explaining why that's not okay and why my patient needs earlier access to highly effective medicines. And we give rational reasons why. That's why I take peer-to-peer phone calls with well-intending doctors that work for insurance companies where we discuss the patient's case and I try to help them understand. One time, someone tried to insult me and they said I was like a medical flea. I was the last thing to jump off a dying dog. I took that as a great compliment because the thing the insurance company doesn't understand is I will not quit. And I have entire team members that are really good at writing letters and they write them all the time. That's one thing that can be done. What else can be done? You can call your legislation. Seriously. You can call your governor or your senator and say, hey, guess what? This is not okay. You can call your congressman and say, guess what? This is not okay. If you want your voice to be heard louder, you can join the MS Coalition or many of the MS patient advocacy organizations that even have lobbies that go to Capitol Hill. There's a lot of things that we can do, and I think we have to fight that fight. I sleep at night because if we can't get something that you need, it's despite my very best efforts. Excellent question. Thank you, Christine.
Great. Thank you for that. All right, next one. Person writes that they're in a flare with dizziness and looking for helpful suggestions. But also for those, let's extend it out, those that have vertigo on a regular basis.
Yep.
What can you do for that?
So this is a very good question. The person says, I have vertigo, what can I do? Right? First of all, you're a human being, not a textbook. So you don't experience an MS attack You experience a symptom. You have a sensation. In this case, it's a hallucination of spinning. You don't know necessarily why you have spinning. You just know that it seems like you're on a merry-go-round and it makes you want to puke. And so the first thing that we must do is communicate. If you're having vertigo and it lasts for 10 seconds, you do not need to call my office. You can tell me about it when I see you next time. But if you have vertigo and it lasts for a day, you better call me. MS is caused by inflammation. And an inflammatory new attack is not going to go away in a day. And if you have a new neurological symptom for longer than a day, boy, I really need a phone call so we can check it out. Now, there are other things that cause vertigo. You could have an inner ear infection. You could have a different neurological condition. There's a bunch of things that can happen. And so we're going to start by communicating and then by examining and trying to figure it out. Now, if we identify that the vertigo is an acute attack of MS, we might be able to help with steroids. If we identify that this is a chronic symptom, which is kind of smoldering and not going away anytime soon, then we can try to use two things to make it better. My fave, vestibular physical therapy. Vestibular physical therapists are ninjas that look like normal humans, and they can make you not dizzy by doing special maneuvers with your head and by retraining your body. Really cool vestibular PT. We also can use lotions and potions. There are some medicines that can help some types of vertigo. But remember, it's all predicated on you sharing with your clinician what's the dealio.
Thank you. Next one is person that's here.
Are they making progress on developing medications that will remyelinate?
So the gentleman asks a very contemporary question. He says, hey, Aaron, can you give me an update on remyelination therapy? So the short answer is not yet. But just to help everyone kind of level set understanding, to really beat MS, I think we need three kinds of therapies. We need anti-inflammatories, which is most of what we have now. We also need a neuroprotective agent, which doesn't exist. And we also need a remyelinating agent, which we're working on. So myelin is the equivalent of the plastic coating on the wire. So your axon, the nerve in your brain, is coated with this fatty substance that's white. It's called myelin. And one of the bad things that happens in MS is MS eats the myelin. And so it kind of strips the wire naked, and it can break the wire, and you can't conduct electricity, and that causes neurological injury. And so if we came up with a medicine that remyelinated it, put the myelin back on, that would be awesome. And we're desperately trying to figure that out. We've had a couple almost successes. There's a drug, upadacitinib, that I was involved in testing, and it's a very long story, and the end was it wasn't found to be successful. But I think about that great guy, Yogi Berra. He said, if we keep banging on the door, one day we're going to break it down. And I think we will. In fact, I'll go out on a limb and tell you that I think that we will have a remyelinating agent in less than a decade available in clinical practice. So it's December 2021. Let's talk in 10 years.
Great, thank you. Next question from the field.
Hi, my question goes back to like the hard-hitting drugs in the beginning. If you were given like some Novantrone years ago, are you aware of, or is there a way to find out, does that interact badly with any current medications like Mavenclad? Because I know there's certain drugs you can't, you know.
Yep. So the young lady's asking a question about highly effective medicines, and specifically asking about an older medicine called mitoxantrone, or codename for Novantrone. Now, if you're familiar with Novantrone, that was the blue medicine. It was this blue IV bag that ran an IV in your arm, and it's hardcore chemotherapy. It's actually the very first FDA-approved highly effective medicine. It's approved for active SPMS and for relapsing MS, and it's a really, really effective therapy. The problem with mitoxantrone is there's a 1 in 100 chance of leukemia, and there's a chance of cardiomyopathy. And so because of those side effects in the United States and in Europe, we've kind of shied away from it, and most of us don't use Novantrone any longer. Now her question is, if you were exposed to mitoxantrone back in the day, what does that do for options today? And the good news is it doesn't change the options almost at all. When I meet a patient who's been on Novantrone, first thing I do is I get a MUGA test, which is like an echocardiogram to look at their heart function to make sure that they don't have a cardiomyopathy, to make sure that their heart is healthy. The other thing I do is I'll check some labs to kind of look at their cells and kind of see where they are. And at that point, we can go in guns a-blazing. There's one caveat. There's a drug called Tysabri, a very effective drug, But if you're on Tysabri and you've had prior chemo, there's a couple risks. It doesn't mean you can't have Tysabri. It just means that if you've had mitoxantrone in the past, there's a couple different discussions that need to happen before you can go on that particular drug. Good question. Thank you.
Okay, I'll be back in a moment, okay? Let me get some of these online, and then I'll come back to you, and I'll get to everybody else around
We've got
here.
someone in the back of the room when you're ready.
Okay, I'll get there as well. Thank you. All right, next person is a person named Stephanie. Stephanie. There's a lot of Stephanies out there, Stephanie. I'm sorry I said your name, but you're not the only Stephanie. All right, I have no family members with MS, but in previous generations, there were family members that lost the ability to walk. Did MS go by a different name many years ago? Can you share a brief history? Thank you.
Yes. So Stephanie, that was a great question. Really kind of speaking about the history of MS. The very first person with MS was described, I think, in 1300. It was a prince that was having trouble writing and kept a journal. And so we can go back in the 1600s and see evidence of people that wrote about having a condition which we now think is probably MS. We started to use the terminology that we use today probably around the 50s and 60s. And I don't think that your family members had MS by a different name. I'll tell you that in generations ago, we didn't do things the way that we did now. It wasn't that long ago, and I'm embarrassed to share this with you, it wasn't that a couple generations of doctors ago, they would say if you were diagnosed with MS, don't tell the young lady. Tell her family, but don't tell her. And tell her not to go outside and that she should never have children or exercise and to take it easy on the couch. And that makes me really pissed off. And on behalf of doctors, I will apologize to all of you for that. That's not okay. We have become sensitized about MS. Stuart sometimes tells a story that he used to inject a medicine with the President of the United States every week. I love that story. Stuart was referencing a TV show where the character on TV had MS. And that is very important to me as an MS clinician in this space because it helps normalize MS. Sometimes people say negative things about MS commercials. You'll see a commercial for an MS drug on TV. I actually love that, not for the actual commercial, but because it's normalizing MS on national television. So we are getting better at diagnosing MS. We used to think that men couldn't get MS very often. Not true. We used to think that African Americans and folks that are Hispanic or Asian couldn't get MS. Not true. We're becoming better at it. We're diagnosing it faster, which allows us to put people on therapy earlier. It's a work in progress, but we've got a lot better, and I'm proud of that.
Thank you for that. And by the way, for everybody that wants to know what show it was on TV, it was called West Wing, and it was played by Martin Sheen. And once upon a time, I was on Avonex a very long time ago, and I made sure to be home every weekend to do my Avonex because I used to be on the road traveling in and out of the country all the time. So I got to come home and watch West Wing and do my Avonex shot with the President of the United States. Okay, thank you. All right, here's a question from back here, and then I'm going to go to the front of the room and get from the other person.
Hi, I just wanted to know how close do you think we are in the U.S. to getting stem cell transplantation for MS as a treatment option for patients who have maybe not done well on anything else, and or just want to go that route with their treatment?
The young lady's question is, where are we in the evolution of stem cell transplantation to treat people with MS? Maybe someone who's in the United States. And so right now, it is not remotely prime time, not to be done outside of research. Right now in the United States, if you want to be proper, we need to find an MS clinical trial. For example, my friend Jeff Cohen up at the Cleveland Clinic is doing an outstanding stem cell transplant trial. Back in the day when I worked at a university, I was involved in a stem cell transplant trial called the HOLT trial. And looking for stem cell transplantation in the context of a clinical trial is very, very reasonable in my mind. I do not think it's yet appropriate to seek stem cell transplantations outside of research. And I have some really mixed feelings about stem cell tourism. Stem cell tourism is actually a really major problem that the FDA is currently cracking down on, where you can pay someone a lot of money and you fly to an exotic location like India or Mexico or Chicago and get your bone marrow swapped out. And there are risks with that. And so I'm very excited about the stem cell transplant story. I think that we're probably closer to stem cell transplantation entering prime time than we are with remyelination. And so my point here is I think within a decade that's going to be on the table for active disease. Good question, thank you.
Thank you. Aside from the cost of going out of the country to get stem cell transplant, isn't like part of the major problems, like if something does go wrong, what the hell do they know here in the States?
Stuart brings up a good point. It's not the cost that bothers me. I mean, I'm bothered by that, but that's not the major issue. The problem if you fly to an exotic location is I'm not exactly sure what they're doing to you. And I've received some patients that come back and they don't know what was done to them. They don't have any notes, they don't have a regimen, they don't have a protocol, and they're just told, well, go see your doctor and he'll take care of you. But somebody has done something to their immune system and I can't figure out what it is, and that's terrifying. A stem cell transplantation is not for the faint of heart. Not at all. It is arguably the most morbid procedure that I can think of. You take someone's bone marrow and you force it to make stem cells, and then you pull those out and put them on ice. Then you murder the human being by giving them lethal doses of chemotherapy so they have no immune system. So they would succumb to the flu. And before, God forbid, they are infected, you give them back an immune system and pray that it takes with the goal of reconstituting their immune response. And then there's a period where they're trying to build an immune system and they're at grave risk of infection. So it's not a benign procedure. And it shouldn't be done outside of careful consideration under proper, safe environment. And so my biggest problem if you fly to India, for example, or Russia is I don't know what they're doing to you and I'm not sure how to take care of you very easily when you return.
Thank you. Next question from here.
I'll just tell you, I hadn't seen West Wing since the show ended, but I just finished watching all seasons a couple weeks ago.
That's great.
It's a great thing to see again.
Show, yeah.
It is. Anyway, sorry. What's your thoughts on patients wanting to switch medications if they're stable, simply just to, like, say, taking a daily medication to one of the newer ones that maybe you just take a couple times and you're done? I mean,
So,
do you think it's risky to
she
take
brings up
the
a
chance?
great point. She says, hey, if I'm on a disease-modifying therapy and I'm okay, like I'm not having attacks and stuff, but I want to switch to a different one because it has other advantages, like it's less often, it's easier to take, it's easier to tolerate, is that okay? Yes. So how many of you owned a cell phone in 1990? Show of hands. How many of you owned a cell phone in 2000? Okay, everyone that owned a cell phone in 2000, get it out and let me see it. Let me see it. Where is it? Why don't you have it? No, I'm serious. What's wrong with your cell phone from the 2000s? It worked. You call your husband, tell him you're going to be late. The reason is because there's been advances in technology. And nowadays, newer cell phones can still call your husband, tell him you're late, but they can also be a translator. They can also order a piano to your house. I mean, they're supercomputers. They can fly and stuff. And when you're thinking about a medicine, you're allowed to think holistically. I mean, in my mind, I'm going to switch a medicine if one of 5 things happen. Any of these 5 things are rationale for discussing switch. Number 1, you have an attack. So that's kind of a duh. But if you're on a drug to prevent attacks and you have an attack, that's not okay, so that might be a discussion to switch. Another one is you have new spots on your MRI. We're taking a drug to prevent spots, so you get spots, that's not okay. Another one is your exam changes, so you're getting worse, right? So those are reasons to switch. But I have 2 other fingers. What are they? This one is I don't tolerate the therapy anymore. I used to think taking a shot 3 times a week was okay. That was 10 years ago. I'm no longer okay with it. I would like to do something different. Is that fair? Yes. I can't remember to take my pill twice a day. I would like to remember. My doctor would like me to remember. My wife would like, but I can't remember. And so I'm constantly forgetting my pill. That's a reason to switch. So that's an okay reason to switch. A 5th reason is if you are no longer safe and comfortable with the side effect profile. So you can imagine a medicine that you're on at time point now, you're okay with, and then as things change, whether that's because we got older or there's other things going on, maybe that drug isn't as safe as it used to be, and we might need to switch then. And so in her question, if I'm on something and I want to go on to something that makes my life easier, is that okay to talk about? Absolutely yes. Again, it is your body, it's your brain, and it's your insurance money. So I think you have a lot of say in what you take. Just my opinion.
Okay, next from online, Julio is asking if Kisimta is a good induction therapy.
Hey, Julio. So Kisimta is an anti-CD20. In English, Kisimta is a B-cell depleter. It's in a family of drugs like ocrelizumab, Ocrevus, rituximab, and there's a couple other ones that are coming down the pipeline. And these medicines deplete B cells, which is a highly effective way of treating MS, but it is not induction therapy. Using Kisimta up front would be my example of early, highly effective therapy. It's not induction therapy, Julio, because we're not rebooting the immune response. We're just killing cells and keeping them dead. And that's a very effective way of treating MS. That's called chronic suppression. It's outstanding to treat MS, but it's not induction therapy. It is a very highly effective way of treating MS, using a B-cell depleter up front. Good question, Julio. Thank you.
Good, thank you. Next, we have one from Susan. Wants to know, for people that are on Copaxone for a long period of time without ever having lesions, do you consider taking a person to take rather a higher efficacy DMT, because this person's understanding that Copaxone is not high efficacy?
So the person's asking, if I'm taking Copaxone and I'm not having new spots, do I need to change? Well, I think there's more to MS than spots. So if you're on Copaxone and don't have new MRI lesions, that's good. But there's more that we need to know. Are you talking about bright spots, enhancing spots, or dark spots? All three matter to me. By the way, what's your brain volume like? Is your brain volume shrinking too fast? In other words, there's other stuff on the MRI that matters than just spots. By the way, have we looked at your spinal cord? And I'm not just going to stop looking at your MRI. How are you doing? Are you having trouble at work and getting written up for having difficulties you didn't used to have? Are you no longer able to work? Should we do neuropsych testing and dig into how you're doing with thinking and memory compared to a couple years ago or your peers? When I examine you, am I finding that you're having problems? Can you still hop on one foot? Are you having trouble doing that? Are you backing away from the litmus test of life? My point is, spot no spot is a myopic way of thinking about MS. It's an important element, but it's one element amongst many that we need to check to figure out if it's okay. And if we're seeing any of those things not okay, I'm not okay. Let me tell you a quick story. Actually, that's a lie. I can't tell stories quickly. I take care of a patient who is on a low-dose interferon, and that's not a drug that I think is very good. So I would not have picked that drug for her. And she's been on that drug for a very long time, 10, 12, maybe 17 years, I don't remember right now. And the whole time she's been on it, she's been a super responder. She's a rock star. No attacks, no new spots, no brain volume loss. I've got neuropsych testing in her, gorgeous. Exam, normal. She's a floor nurse, works double shifts all the time, ain't nothing but a thing. Yes, she has MS. She responds beautifully to Avonex. So every time I see her, we have the same conversation. Go ahead, Dr. B, tell me how you don't like my drug. I know, but in you, you're doing great. Ha, 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 ha. So I'm okay with that. In her, that's doing great. But my point is, we have to really look deeply, not just at one thing, at all things, to make sure that we're not slipping without realizing it.
Thank you. Next, from online, Christine again. What about using post-processing volumetric MRI, for example, NeuroQuant, MS lesion quant, to help track disease progress and help identify disease changes before relapses to make decisions about DMTs? Also, should this technology be incorporated into DMT clinical trials?
So I'm going to assume that that's the same Christine that asked me the last question, because that's
Yes.
another really great question.
Yes.
And I didn't pay that particular Christine to ask that question, but I could. So they're asking a really cool question that's something I really enjoy talking about. So thank you. Remember how I just mentioned, is your brain shrinking too fast? Like, that's important to look at? So the old school way of doing that is to get out literally a ruler and measure aspects of the MRI, which is all ghetto fabulous and not the best way to do it. There are better ways to measure brain volume, and the software that this gal mentioned is the software that I use. It's called NeuroQuant. NeuroQuant increases the price of the MRI by less than $100. And what it does is it gives us a volumetric analysis. In English, it measures the size of your brain and all the pieces of your brain, and it compares it to people your age and gender. And so I can tell you that compared to a bunch of people your age and gender, here's where your brain is compared to there in size. And we can see if your brain has shrunk faster than it's supposed to. And by checking it over time, meaning across several years, we can see if it's getting too small too quickly. It's an awesome technology, and I get it with every brain MRI that I order. So at the Boster Center for MS, we're looking at brain volume in clinical practice because I think it's relevant. Great question. I think it's an important thing, and it's becoming increasingly more important. Brain volume loss or brain shrinkage is one of the best correlates to long-term disability. And not all MS medicines can slow brain volume loss. Some do it really good and some don't do it very well at all. So for fun, when you go to see your MS doctor, say, hey doc, does my drug work to slow brain volume loss? And if they say yes, say which papers showed that. Just make sure they know their stuff.
Thank you. Next out here.
I was curious if you could tell your thoughts on the study that they did at Cincinnati Children's, where they were trying to, they were looking at pediatric diabetes. I think it was juvenile diabetes, and they were doing some kind of digital study with the, I guess, DNA or mapping genes, and they found a gene that I think it was a gene that linked, if you had this certain type of gene and you got mononucleosis or some kind of Epstein-Barr virus when you were younger, that you were likely to have one of 7 different diseases later in life, like MS, IBS, like Crohn's or inflammatory bowel disease, diabetes, a certain type of diabetes, lupus, rheumatoid arthritis, things like that. And so I'm just curious on your thoughts on that. Like if you had, for instance, if you had 5 children and 3 of them got mono when they were kids and 2 didn't, could 3 of them get, those 3 get diseases and the 2 not?
Yep.
Is that basically what it's saying?
She's asking a question about what causes MS. Now, the particular trial that you're mentioning, I'm not familiar with, but I am familiar with the literature in general, so I think I can still speak to kind of your question. We don't know what causes MS, but we're getting closer to understanding it. And today I can tell you what I call the party line, like kind of where we are with our current understanding. And as you listen to this 10 years from now, you can laugh at me. So what we think is that there are certain genes which predispose groups of humans to be more or less likely to experience autoimmunity. So you share genes with people that come from areas in the world like you. So you can trace the genes that encode for your skin color, typically, or your hair color, or your eye color, to a location in the world. Like many folks in the Midwest trace their heritage back to Western or Northern Europe, for example, right? And so those people in the Midwest tend to share similar genes, including genes that encode for the immune system. There are certain groups of people that, as a result, tend to have more autoimmunity as a group of people compared to another group of people. I'll give you an example. Pasty white people in Ohio have a lot higher incidence of MS than folks that live in Morocco, right? So that's a population of people where you see less MS, just genetically. Now, that's not enough to give you autoimmunity, and that's what the young lady was talking about. We think that with a genetic predisposition, you're a little bit more likely, but that's not enough. We then think that there are environmental risk factors which can further increase or decrease a given human's risk to get MS. Some of those we've identified. Exposure to mononucleosis pre-puberty increases the likelihood you get MS, we believe. Morbid obesity and inactivity pre-puberty doubles the risk to get MS. Exposure to smoke, including secondhand smoke, doubles your risk to get MS. Low levels of vitamin D pre-puberty increase the risk to get MS. So we take that genetic predisposition and then we ratchet it up or ratchet it down based on those risk factors. That's not enough to give you MS. We then think that your body sees a virus and your body tries to fight the virus, and it makes accidentally an arsenal that identifies your brain as the virus and starts to attack your brain thinking it's doing a good thing. That's called autoimmunity, specifically MS. So what can we do with that information? We can't change genes. Well, not easily. But what we can do is we can address the environmental risk factors. And so no parent that I'm aware of looks at their son and says, "Smoke up, Johnny!" But I think there's an additional reason why a family with MS would want to educate their children not to smoke, because it would double their risk to get MS. Now, if you're the child of someone with MS, your risk is about 1 in 40. And so if you smoke, when you double it, that's 1 in 20. That's a pretty high risk. Great question. Thank you for asking. So the gal in the back of the room says, when can I stop taking my MS medicine? And that is a very, very hot topic right now. There's a lot of MS neurologists like myself that are arguing about that. And there's two camps. The folks that are wrong and me. And so let me break it down for you. So there's a bunch of people that are dead wrong that think that they can be ageist. And if you reach a certain chronologic age, well, you've lived a hell of a life, good job, let's stop your medicine, all right? And the rationale scientifically is supposed to be that, and this part's true, as you age, your immune system gets quieter, and we don't study the drugs in older folks as readily, and they might not work as well. Okay. But maybe the reason that you're doing well and haven't had an attack in 5 years is because the medicine's working. Moreover, these drugs do more than stop attacks in new spots. They slow brain volume loss. They slow disability progression. We've done studies of people that have progression to the point where they use a wheelchair, and on drugs, they maintain hand function. Anyone that has used an assist device knows that in an assist device like a wheelchair, your hands are also your feet. They become even more important, even more reason to want to hold on to them. And so taking you off that medicine, in my mind, would be a travesty. My answer to your question is I draw a line in the sand and I refuse to treat beyond death. When you die, I'm not giving you an MS medicine because it won't work. But before that, as long as you have a nervous function that you like seeing or smelling or hearing or talking or moving, then I want to try to preserve the reserve, preserve the neurological reserve, preserve your brain function by giving you a medicine. Now, it might be the situation where we de-escalate the intensity of the medicine when you enter 65 years of age or 75 years of age. We may de-escalate the medicine so that it's less oomphy and less concerning from a side effect standpoint, but I'm not in favor of stopping the medicine. So the first thing is, I don't think that we should be punitive and like, roar, 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 roar. Because if we act like that, the human will run away. And then I can't help them, right? So if you are too aggressive with someone when they want to take a holiday, they'll get upset and they'll leave, and that doesn't help them. And so I don't think that's the right approach necessarily. I used to. But what I think we need to do is we need to talk about why you want to take a drug holiday. What about it makes you want to do that? And I need to be a good listener when I ask you that question. Because I might be able to take care of the problem without stopping the medicine. I might not. That might be a rationale to switch medicines onto something else. And I'll tell you what, Stuart, there's been times I've said, okay. I tell them that they do it at a risk. I explain the risk. And we set a set period of time. And we do a pinky promise. And I see them back and we start back on. Because I'm doing this game for the long haul with them. And a month off drug to clear your head, I can, in some situations, handle that. So I think it's a discussion, actually.
Okay, thank you. Next question. Why don't psychiatrists or psychologists understand the importance of managing mental health with multiple sclerosis?
So the person asked, why don't psychologists and psychiatrists understand folks with MS mental health concerns? Respectfully, I think a lot of them do. Now, everybody's different, and a psychologist might have a predilection towards working with a particular group of people. Like there are psychologists that specialize in transgender issues. There are psychologists that specialize in family counseling. There are psychologists that specialize in addiction. There are psychologists that specialize in MS. Whoever asked that question, I want you to jump online and check out a friend of mine named Dr. Sullivan. Dr. Amy Sullivan is the head of behavioral health at the Cleveland Clinic. She's arguably one of the most amazing psychologists in the United States and probably the top specialist in MS psychology. She has trained innumerate psychologists that now go out in the world and beat MS mental health because of her. She has an amazing program. And so if you don't know her, you should check her out online. Now, another thing about psychiatrists and psychologists, if they don't know, teach them. Bring them information. Bring them my note. Explain to them what's going on. Invest in that relationship so that you can get some return on your investment. And if they are truly not listening, you may have to find a different partner in your mental health care. You may need to find a different therapist or a different psychiatrist who is going to be a better job listening. I think, again, it's any intimate relationship, and a doctor-patient relationship is intimate, requires work and communication. And so I would start by saying, I just don't feel like you're hearing me. I'm trying to tell you this thing, and I'm having trouble because I don't feel like you're picking up what I'm putting down, doc. That's a fair thing to say because it's all about you and your brain and your body. Good question.
Okay, next one. Person is asking, how if a person gets COVID-19, what is their impact for having MS?
So we meet today separated by more than 6 feet as I look out on the audience wearing masks, and even more of you are online safe at home. We're not done yet with this global viral pandemic, and it's scary. I want to share something with you that I don't generally share. This year, I sat down and wrote 4 letters to families of mine of patients who died from COVID. My wife handcrafted an ornament for each one of their families with a cardinal and with some information on the back. And we sent them to them. I lost 4 families this year. It's 4 too many. We're not done with this global viral pandemic. And the impact on people impacted by MS can be more severe than the general population. Having MS doesn't increase your risk of a more severe COVID unless you have very severe MS and have trouble arms, legs, and breathing type stuff. But many of the medicines that we give people for MS suppress their immune response, and some of them can actually increase the risk of a more severe COVID. Moreover, some of the MS medicines can interfere with mounting an immune response to the vaccine. And so that's a very, very real question. I want you to be 3 for 3 in your fight against COVID. This is 3 things I want you to do. I want you to be 3 for 3. Number 1, I want you to mask up. It's not hard. It's not political. It saves lives. Wear a freaking mask, please. That's number 1, mask up. Number 2, get boosted, right? I am very pro-vaccination. I'm a neuroimmunologist who believes in the science of vaccinations, which have saved millions of lives and eradicated terrible diseases. And it's my strong belief that people impacted by MS benefit from getting COVID vaccines and boosters. And I can defend my information with solid science. So I want you to get boosted. That's number 2. That's my opinion. Number 3, stay out of the fray. You're not in the fray right now. You're segregated by 6 feet and wearing masks when you're not chewing. And we need to not go to big, gigantic parties where there's a cotillion of 900 people all dancing in a room next door, all tight together. That's not the right time. I have a patient who is on an MS medicine which prevents her from mounting an immune response despite getting 3 vaccines, and she got COVID and was in the ICU for a month. That's a true story. She doesn't mount an immune response yet. She's home now. And I saw her in telemedicine, and she said, Dr. Boster, I know your answer. I have to ask you this question. My sister's getting married in Florida, and they want me to fly down. And I said, honey, please don't. I said, tell them it's my fault. Tell them I wouldn't let you. I can't have you do that because I can't keep you safe, even with the mask. So she's going to blame it on me. This is a very, very serious thing, COVID-19. It's not to be trifled with. It's not fake. And there's 3 things that I'm aware of that can help you and me. So I want you to mask up. I want you to get boosted and stay out of the fray. Great question.
Great. And before I get to the next ones, I just want to let everybody know, there were a lot of people at the beginning of the vaccines coming out that was saying, I'm not doing it until the FDA approves it. Well, guess what, everybody? It's been approved. So do it. What excuse are you going to come up with now? All right? And don't say it's a Russian thing or it was a political thing or it was a way because of something that had to do with our politics. Because it really wasn't. All right? I mean, why did the rest of the world get it? Why did everybody from all of the UK, Europe, okay, Russia, Africa, why are they having all these same problems everywhere else? And they don't have an FDA, all right? And yet they're still trying to get these vaccinations into everybody that's around. It's for a reason, all right? So, again, I want to be safe and going forward. I hope you all are too. Next question. Person's asking about MRI and contrast.
That's a good question. So, show of hands if you've ever gone into a really tight tunnel that's super loud and with a cage on your face. Keep your hand up if you paid a bunch of money to have that done. Yeah, me too. An MRI is not remotely fun. I'm actually very claustrophobic, so when I have to send you to a scanner, I'm sorry. It freaks me out. But it turns out that the MRI machine is hands down the very best biomarker we have available to diagnose MS and then to monitor MS, specifically to monitor your response to therapy. And when you have the MRI, you know how when you're laying in the cage in that tunnel and it makes different sounds? It'll go like bang, 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 and then a while later it'll go bing, 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 bing. Those different sounds are different kinds of pictures. So when we get an MRI, we get several different kinds of pictures that teach us different things about your brain. At some point during the scan, the tech pulls you back out of the gantry and injects you with this warm stuff that makes you think that you're going to pee your pants in the scanner. You get warm all over your body. Nobody actually ever pees their pants. And they put you back in the scanner, and then the scanner makes other noises. Bang, 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 bang. Those pictures are chasing dye. When they inject you, what they're injecting you with is a dye called gadolinium. And it's a contrast agent. And when they take the MRI, it lights up all the blood vessels. So imagine that if you had like a stream and you poured like green food coloring into it and then took a picture, you could take a picture as the green came by. You could see the green. And so by taking an MRI, you can see all the blood vessels. If there's been a breach of the blood-brain barrier, the barrier between the bloodstream and the brain, because of a new MS lesion, the dye will leak into the brain temporarily. And so one of your lesions will light up like a Christmas tree light bulb. And if we see that, it tells us that it's a new lesion now, like at the time we're looking at it, because they only stay enhancing for about 2 weeks, maybe up to 4 weeks. So here's the deal. If you allow me, I'm going to get all your scans with and without contrast because I learn more information. But if you are uncomfortable with dye, after the diagnosis piece, when we're monitoring you, I can get it without contrast, I just don't learn as much. So if you're willing to accept that I might miss a little bit, then okay, we can do it without dye. But if you're asking me to get the most information possible, I would prefer to use the dye. Now, there's some concerns about contrast dye. The biggest concern is if it hurts your kidneys or it gets trapped in your brain. And there's even been some actors and actresses that have taken it upon themselves to proselytize stuff, and unfortunately some of it's not true. Here's what is true. There's different kinds of gadolinium agents, like different molecules. There's linear gadolinium, linear like a line, and that's the kind you do not want. Linear gadolinium can get sequestered in your brain, and honestly, I've never worked in a place that used linear gadolinium ever. There's a different kind of gadolinium, it's called macrocyclic, cyclic like a circle. Macrocyclic gadolinium does not sequester in your brain, and it's safe. Also, we check kidney functions before we put people in the scanner to know whether it's safe to give them contrast. At the end of the day, it's your brain, and if you don't want me to use contrast, I'm not going to. I'm just not going to learn as much, and there's a small risk that we may miss something, and that's okay. Great question. So Susan's asking, how often should MRIs with contrast be done? I'm going to change her question and say, how often should MRIs be done? So MRIs are darn necessary to diagnose MS. You can do it without an MRI, it's just really, 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 really hard. Once you clarify the diagnosis, the use of the MRI changes. So it's no longer to diagnose, we did that. It's to monitor and see evolution. We're looking for structural damage. So if I have an MRI today, a year from now, I'm going to get a second MRI, and I'm going to compare it to today's MRI. And each spot on your new MRI, I'm going to try to find it on the first MRI I did. And if every new spot was seen a year ago, none of them are brand new, they're all old, I ain't worried about it. If I see that one of your old spots got bigger, I'm not okay with that. If I see there's a new spot, I'm not okay with that. If I see a new dark spot, I'm not okay with that. If I see a new enhancing lesion, I'm not okay with that. Oh, and by the way, if I see brain volume loss, I'm not okay with that. So there's a bunch of stuff I'm going to compare the old scan to the new scan. So I kind of spilled the beans. I like to get an MRI brain about once a year. And I like to get an MRI of your spinal cord at least every couple years. And I want to constantly look back and see if anything's changed. There's also an important element about when you start a new drug. So if you start a new MS drug, I'm going to get what I call a re-baseline scan, a new MRI at 6 months. That's my new baseline on that drug, and then I'm going to compare everything to that scan. And so that's a deviation from every year. That's a 6-month time frame as I put you on a new therapy. Now, after the age of 60, I will start to discuss with you if we want to skip a year now and again. That's a discussion. and that's specific to that individual. Great question.
Back here.
You mentioned that some of the DMTs make the vaccine difficult to mount a response. Based on that, if a MS patient is on one of those DMTs, is there a specific vaccine that you would recommend?
Yep, great question. So the gentleman says he understands that some of the MS medicines can interfere with mounting a full vaccine response for COVID, which is a bummer because we want to mount the most robust vaccine response possible. So is there anything you can do to kind of try to help that? That was the question? So, oh, sorry, yeah, so that right now in the United States, let's talk about 3 vaccines, all right? There's 2 mRNA vaccines. One's made by Pfizer, one's made by Moderna, and then there's a J&J vaccine. I'm not recommending the J&J vaccine. The reason I'm not recommending the J&J vaccine is it's not as good. So one J&J vaccine gives you 60% immunity. That's not okay. One Moderna or Pfizer gives you in the high 80s, low 90s, and if you have 2 shots, it scoots it all the way up, so you're protected. So when I pick a medicine, any medicine, my first thing is efficacy. That's not the only thing, but that's my first thing. So I want to know, like, how good is it? And so I want to recommend the more effective ones, particularly if you have trouble mounting a response. Moreover, J&J has 1 shot, and they're working on discussing a booster, so that's maybe 2 if you're lucky. Pfizer and Moderna are 2 shots on purpose, and there's a booster available. So you can get boosted better and longer and higher on those medicines. So I'm not recommending J&J. Now, J&J is not bad. It works. I mean, I'm not trying to like poo-poo. I'm just saying if you're asking my opinion, I lean towards those. And I don't get a kickback from Pfizer, although that'd be nice. Hi, Pfizer. So amongst the Pfizer and the Moderna, there's some evidence that Moderna does a better job of mounting antibodies. And so if they said you can have anything you want, which one do you want? I would pick Moderna because of the antibody piece. But if they said we only have Pfizer, I'd say, okay, that's fine. I don't think it's bad at all. If they said J&J, I actually would ask for the other 2. And that's just my opinion. But if it was a difference of not getting boosted at all and getting J&J, take it.
Next question here.
Going with the vaccine, like, okay, so if you don't have a response, and let's say you did Pfizer, right? And you don't have a response, would you say maybe go out and try Moderna?
When you say I don't have a response, do you mean they checked antibodies and they weren't able to find antibodies afterwards? So this gets really like kind of nerdy, so sorry. There's a lot of problems with the current state of affairs, and it all has to deal with the fact that we're watching science unfold. When you look backwards at a travesty, you can be, oh man, that was rough. The AIDS epidemic of the 80s, that was terrible. Oh my goodness gracious. Thank goodness there's all these great drugs. That's not what we were saying in the 80s when people were dying, right? I mean, and so right now, we're watching science unfold. The first problem is that the tests, the blood tests to check for antibody response were developed before the vaccines were developed. They were developed to see if you got an infection, and they don't measure vaccine response properly. Just for fun, read the package insert to the test that you had. It states in bold letters in all capitals, do not use to assess vaccine response, because they didn't make the test for that purpose. Now, I sort of feel like every American doctor just chooses to ignore that because they're using it for that purpose. But if you get a negative result, it's a little bit unclear exactly what that means. Moreover, if you read the information about vaccines for COVID, it states that you may mount a delayed response if you are immunosuppressed. Moreover, when you give someone a vaccine, any vaccine, you trigger a B cell response, which makes antibodies, and a T cell response, which makes cells that can kill the virus. We measure antibodies, we never measure T cells, except for in special laboratories. You can't get a T cell test. So we don't know if you mount T cell response or not because we didn't check it. Now, the reality is, if you're on certain MS medicines that have been shown not to help mount response, you probably are negative. And even if we don't know, I want you to pretend you're negative because that way you'll be safe. But what I really want is access to some of these better tests that are currently available only in research institutes, mostly outside the United States, to be able to do a better job of assessing.
I was wondering, as pertaining to MS drugs, where Aubagio fits in.
Aubagio was once called the little engine that could. Remember the book, The Little Engine That Could? And I think that's a very apt description for the drug Aubagio. So Aubagio is a pill taken once a day for MS. It's one of the 25 different formulations of drugs approved for MS. And Aubagio is interesting. It's not a rock star at stopping new attacks. It's okay at it. It's not great at it. It is not a rock star at stopping new enhancing spots on the MRI. It's okay at that. But it's a rock star at slowing brain volume loss, and it is a rock star at slowing disability progression. Allow me to explain. There was a recent trial called the Exclepios Trial. That's a funny name. The Exclepios Trial compared Aubagio against Kisimta, which is the MS drug that we talked about earlier today. And Kisimta beat Aubagio when you looked at relapses and when you looked at MRI, new inflammation, which is not to be surprised because that's not Aubagio's strength. But it wasn't able to show that you could improve MS more with one drug or the other. And it was barely able to show a difference in disability, and it wasn't able to show brain shrinkage change very much comparing the two drugs. And so it's really interesting that the little engine that could actually perform pretty darn well on a lot of the things that I think are relevant in the second half of the disease. So I use Aubagio a lot, but not up front. I use Aubagio as a de-escalation maneuver. When you and I have controlled your disease for a while, we're grooving and you're doing okay, except you don't want the risk profile of the high efficacy drug that you're on any longer, and maybe you don't need it as much. And so there may be a situation that we switch to Aubagio to de-escalate the risk, but keep you covered, particularly slowing brain volume loss and slowing disability progression. I made a video a couple years ago and I said, should we still use Aubagio? And the punchline is yes, but in the second half of the disease. That's my opinion.
Okay, next one from over here.
Could you explain the importance of exercise and the consequences of not exercising? Thank you.
So the gal asks, can you please explain the importance of exercise in the setting of MS? And like what happens if you don't, right? So that's a great question. I preach that I want you to be 5 for 5 in your fight against MS. You ever heard that? I want you to be 5 for 5. One of the 5 things is to exercise as part of your lifestyle. Because exercising as part of your lifestyle has been shown to slow the natural progression of MS. It maintains brain volume. It maintains cognition. It improves energy levels. Did you hear what I just said? It improves energy levels. It improves sleep. It improves balance and a bunch of other things. But before I get into all that jibber jabber, let's just do a thought experiment, okay? Let's take yourself, get permission from your spouse, and clone you. Now there's 2 of you. Congratulations, sir. And we're going to give one of you chocolate cake and Days of Our Lives TV. And we're going to give the other one of you a stationary bicycle and carrots. And we're going to get back together in 4 years. And we're going to discover the first clone knows everything there is to know about chocolate cake and Days of Our Lives TV, but she's gained some extra pounds and has weak core and weak legs, and cardiovascular is not so awesome, flexibility stinks, balance is not so good. And over here we find a Greek goddess who lost a couple pounds and got a strong core and strong legs, great balance, cardiovascular endurance has never been better, flexible like she's never been before. So you got 2 clones of you. And then I'm going to reach into my pocket and pull out a Harry Potter magic wand, and I'm going to cast a spell and cause an attack of left leg weakness. Expelliarmus! And both clones are going to have a weak left leg. This clone, who has been prehabilitated, who has been in shape, she's limping. She's going to rehab and she hasn't stopped what she's doing. This clone is seated in a wheelchair looking up. I'm not going to insult anyone in the room and say, which one do you want to be? It's a rhetorical question. But my point is, what's important is prehabilitation. We want to preserve the reserve. I don't want you to have to rehab after you lost a function. I want you to be in such good shape that it takes less of a hit. Exercise is really important. Now, it's not easy to exercise with MS, so that's not fair to be like, well, just get out there and run, young man. That's not fair. And so I think it's worthwhile to talk a little bit about options for exercise that are viable. Right? One of the homework assignments that I give all new consult patients is as follows. Write down for me 2 realistic options for exercise in your life. That does not mean that you can come in here and tell me you're going to be an MMA fighter, because no, you're not. That does not mean you can come in here and tell me that you're going to run a marathon. Well, you're probably not. But I want to know, what can you do? So for example, show of hands, how many of you have an elliptical, treadmill, stationary bike that's in some back room in your house, in a spare bedroom, or in your basement? Come on, be honest. Get your hands up. About half of you should raise your hands. Now, keep your hand up if you put clothes on that piece of equipment. I did. Yep. So what I want you to do is not very feng shui. Get your spouse to drag that bad boy out of the spare bedroom into your living room right next to the lazy boy recliner. Just try it. What will happen, most red-blooded Americans watch 2 to 4 hours of television every night. So you'll be sitting there in your nightgown with your spouse watching TV, looking at Netflix, and out of the corner of your eye, you're going to see the red Schwinn stationary bike that you bought 15 years ago and never got on. You watch TV and you're going to keep seeing it. Eventually, you're going to remember the little balding guy. I want you to get on it for 4 minutes. That's all. Not 10 minutes, not the whole. Just get on for 4 minutes and pedal your little tush for a little bit, then get off. Then sit back down. Half an hour later, it's your husband's turn. Oh yeah, we do this as a family. Let him get on for 4 minutes. At the top of every hour you're watching TV, pedal your tush off for 4 minutes. At the bottom of every hour, make him do it. If you do that, you'll get 10 to 30 minutes of exercising every night while you're watching the boob tube. There's a lot of ways to game out exercise. Water is magic in MS. In the water, we weigh less. People that are not able to support their weight standing on the earth can sometimes do it in the water, particularly if you put a life vest on. It's a power of freedom to be able to walk around in the water. You weigh less in the water, so if you have a weak leg, it doesn't matter as much. If you're having a bad day and you're falling this way, the water pushes back that way. And if you get overheated, the water wicks the heat away from your body by convection. Spasticity is less concerning in the water. And so there's a lot of water activities like water Zumba, water aerobics, swimming, walking in the pool. I'm going to tell you a quick story about a very special man. He was my algebra teacher in high school. And I had the honor of being his MS doctor later in his life until he passed away. And he had PPMS before there was a drug to treat PPMS. Now this guy was tall. Now in my memory he was like 6'7", but I'm kind of short, so I don't know exactly. But he was really tall. He's a tall guy. And he was having increasing trouble walking to the point where he was falling with his walker and he was going to need to sit in his scooter. And he didn't want to do that, and neither did I. So we hatched a plan. We got a cheapo walker and a life jacket for real, and he went to the YMCA 3 to 4 days a week, had help getting in the water with a life jacket on, had the walker in the water for real, and he walked laps in the shallow end with his walker with a life jacket on 3 to 4 days a week. And he did that for a couple of months. He came back to me in clinic, and my MA came and got me. He said, Dr. B, your patient will not do the timed 25-foot walk until you come in the hallway. Okay. So I stuck my head out, and there he was. He said, young man, are you ready? I said, yes. And he took his walker, picked it up, and he walked 25 feet. He didn't do that because of a medicine. He did that because he exercised. And we kept him up walking for 2 more years. That's a big deal. And he did that by himself through really hard work. Water's pretty cool. Thanks for asking that question.
All right, next one is from somebody that's asking about sexual health and MS.
Yes. Oh, sorry, I like that topic. Go on.
Yes. So she, as one person, and he, as another person, want to know why they're not feeling anything in their down there's any longer.
Yep.
And what they can do about it to keep things happy and spiced up.
Amen. Now, I'm really glad that somebody asked this question, because one of the biggest determinants of happiness of life amongst adults is intercourse, right? And so you're allowed to want to enjoy intercourse, right? That's a fair thing that you're allowed to want. And MS can affect sexual function. So if you don't want to hear me talk about sex, run. I'm assuming you're either really tired or it's okay. So MS can affect sex, and specifically, it can make it hard to feel stuff. Let me explain. right now, I'm using a relative indoor voice, maybe a little louder than an indoor voice, right? Make sure that the gentleman wearing the Darlin shirt in the back, you can hear me okay, right? Now, if everyone in the room started talking, he wouldn't be able to hear me because there would be a bunch of interference between my mouth and his ear. And so what he would do is he would try to listen more, and I would start yelling. If I talked loud enough, I could overcome the interference, and then he could hear me again. When the down theres are stimulated, it sends a message up the spinal cord, which is really long, up the brain to a center in the brain that says, ha-ha, I know what we're doing. And it sends a message back down to the down theres to help with erections and lubrication and all the circuitry and mechanics of intercourse. Except if you have a spinal cord lesion, or if you have a brain lesion, sometimes the message dies along the way. So the down theres are being stimulated, except the message isn't getting to the brain. The brain never learned what it was going on, and so it didn't respond properly. And so the experience is that doesn't feel like anything, or it hurts. So what we can do is we can provide overdrive stimulation. So I will teach you the plug-in-the-wall vibrator trick. A water-based lubricant increases skin sensitivity anywhere in your body. And a water-based lubricant is easy to clean up. And so the first thing is apply a water-based lubricant to the down theres. You stack the deck in your favor because you increase skin sensitivity. The second thing is a Hitachi magic wand. Yes, I said a Hitachi magic wand. So that's a back massager made in Japan, costs $60 on Amazon. I've bought several in my life. And it's a plug-in-the-wall DC battery vibrator, like plug-in-the-wall hardcore power. And if you apply the Hitachi magic wand with a water-based lubricant to the down theres, it's going to provide overdrive stimulation. And I learned about this trick not from a doctor, but from patients, particularly guys that stole their wife's vibrator and were able to obtain and maintain an erection adequate for penetration by using the vibrator trick. You can use it by yourself, you can use it with your partner, there's all kinds of stuff. And I always joke, if you don't like it, put it back in the box, put a bow on it, and give it to your spouse. Point here is that we have to understand what the problem of the circuitry is, and then there's ways to get around it. There are other tricks and tips. I'll give you one more. That's called Scream Cream. You ever heard of Scream Cream? Scream Cream is a cream that helps you scream. It's made in a compounding pharmacy, and it's made with medicines that engorge tissues with blood flow. And so you can apply it to the down theres, and it increases blood flow and skin sensitivity, and it helps increase the ability to feel sexual content. So that's called Scream Cream. It's good stuff. Very important question. So they're saying, how can I be a better self-advocate? You guys are familiar with the term advocacy? That's like standing up for somebody, like being their support system, like saying, hey, they're an okay person and we need to do right by them. That's an advocate. In healthcare, particularly in the United States, you desperately need a medical advocate. Every single one of us, myself included, needs an advocate when we go see the doctor. When I go see the doctor, I'll oftentimes bring my wife. And she's not a doctor, she's not a nurse, but she's smart and she's a good listener and she likes me most of the time. And so she'll tell me, no, he didn't say that. He said this. And be, oh, thanks, right? She's a good advocate. Or she'll say, shut up and let him talk. And so the best advocate to cultivate is yourself. Remember I told you earlier, you are a you expert? You know you better than everybody else. So you're a great advocate for yourself because you already know about you. And we have to learn to cultivate self-advocacy. My grandparents have passed away. When my grandparents were alive, they came from a generation of doctor knows best, ask no questions. And that was a generation of Americans. You went to the doctor, you didn't ask the doctor questions. He told you the answer and then you just did what he said. I don't like that, and I don't practice that kind of medicine. And quite honestly, I think that we've come a long way. Now I have these sassy millennials that say, nah, which I love that. And then we have conversations and stuff. But my point is, learning to be a self-advocate is really important. You have to say what's important because it's your brain. I'll give you an example. Maybe you say, hey, my leg feels like it's burning, and I don't like that. And the doctor says, well, there's nothing I can do about it. But you can say, okay, well, if you're not good enough to do something about it, do you know anyone else that can? Because I don't like my leg burning. Now you might say it more nicely, but my point is, it's your leg, and if that doctor is having trouble helping you, say, no, okay, but how else can we get it taken care of? You got any other ideas? Now, one way that you can be a good self-advocate, and this is a pro tip in my opinion, is to prep your visits. I prep your visit. When I see you, I read about you before you come in. I look through my notes. I look at your old MRIs before I see you, even if we don't talk about them. I go through all your labs. I am ready to see you. In fact, I write down what I want to talk about before I see you. So when I pull up your note, I'm ready. I know which questions I'm going to ask. You should do the same thing. It's your body. So you want to take some time and write down your questions. Take a picture of all of your medicines, or write down all of your medicines, or bring the bottles in. Make sure that if the doctor wanted to get an MRI, you picked up the disc and brought it. Don't just assume they're going to mail it. It's your brain. Take some initiative to do that. Bring a loved one with you to be a good listener who can take notes for you. Prepare for your visit. MS Visa News has a really cool website, and if you don't know about it, you should. And if you go to their website, they have a form which helps self-advocacy. What's the name of the form? It's like a prep form to go to your clinic visit. It's say it again? Land of MS, which tells me who created it. A friend of mine down in Florida, maybe. So Land of MS is a form that you can print for free off the MS Visa News website. And it's a form, if you fill it out, you're ready. It goes through what are your medicines, what are your questions, how are you doing, X, Y, Z. And so you can just bring the form in. And it's very helpful. I've had patients do it. They come in and say, hey, Dr. Boster, I have this form I want to go over with you. I have questions. That is a cultural sign that I need to go through the questions. Very, very helpful. No, I'm good.
All right. Yes, Land of MS. By the way, you can, for those who cannot talk into their, or those that want to actually print it out, you can actually fill it out online and then print it out to yourself, all right? And you just bring it with you to your doctor's appointment. Basically, everything that you want to know about multiple sclerosis, any of your own questions that you might have, are on that form that you could fill out and be ready for your doctor's appointment.
It's a really good idea.
Okay?
I think.
I know who created it. Okay, so next, we have 2 more questions online, and then we're going to get to a special thing for the local audience, okay? I know you're all waiting for that, right? All right, so from Susan, should people with MS take the shingles vaccine?
So there are certain situations where you might not be ready to take the vaccine because of a medicine that you just took or something like that. So I can't give you a blanket answer. Speaking generally, I want all people with MS to be vaccinated against shingles. But again, you need to talk to your doctor because depending on what medicine you're on may change when it's safe to get vaccinated. And so that's an important discussion to have. But the answer shortly is yes.
Great, and the last question, one that nobody here has asked, marijuana.
Yeah, I was going to say ganja, yeah.
Marijuana.
So this might be the first time, Stuart, that we went through an MS Visa News program and no one in the audience asked me about ganja.
That's right.
I have my feelings hurt.
They don't even know what ganja is.
So, yep. So we're in Louisville, Kentucky right now, and I'm from a state just north in Ohio, and in Ohio, I'm an Ohio medical marijuana recommender, where if you have a qualifying diagnosis of MS, then you can get a medical card, and you can have access to medical cannabis. Now, quick story. When Ohio first passed that law, I was against it. I didn't participate. I thought it was a bad idea. And the reason is I'm a nerd, and I like science. And so there's very, very, very little science supporting the use of medical cannabis in MS. And that bothered me. Because when I ask you to do something, I want to know why I'm asking you. I want to know all the data. I want to make sure that what I'm saying to you makes sense and is safe, etc. And so that was a real sticking point. And so I was kind of poo-pooing it. Then I did something that I should have done earlier. I listened to my patients. And this really weird thing happened. Many 70-something-year-old women privately confided in me that if they smoked a little doobie that their grandson gave them from California, they didn't need the Lyrica or the Baclofen, and they slept through the night, and they woke up without spasticity and didn't have bladder problems. And I said, wow. And then multiple 70-something-year-old ladies secretly confided in me all the same thing, and they didn't know each other. So either A, a bunch of my patients got together and they crafted the funny lie, let's all tell Boster this, or B, maybe it was real. So I went with B, And I started to ask patients more about it, and then I decided to take the plunge, and I went through some courses, and I became a medical marijuana recommender. I can say now, having been recommending MMJ for symptoms related to MS for about 2 years, that I am still a believer, and I think that medical cannabis helps with certain things in MS. Now, it does not help with slowing the disease down. It's not a disease-modifying therapy at all. And it's not magic, and it has side effects, and it can become addictive. So those are very important things to think about. Plus, here it's illegal. But it helps with some things that I think are relevant. The number one thing I think it helps with is spasticity and pain. And so I've had a lot of success using cannabis in different forms to help with spasticity and pain. The second thing it seems to help with is irritability and intolerance of activities. I'll give you a really interesting example. A patient of mine who I find to be very dear is a young man who wants to stay fit and he likes to exercise, so he likes to cycle. But after about 10 minutes, his legs start to burn. He short-circuits the spinal cord and his legs burn so much that he has to stop cycling because it feels like he's on fire. If he uses medical cannabis, he doesn't care. It still burns, but it doesn't hurt as much, and he can keep going. So he uses that to exercise, which I think is pretty clever of him. Kind of neat, right? So another thing that I think it helps with is insomnia. Many people impacted by MS have insomnia. It's actually a major problem. There's a lot of reasons why folks with MS have insomnia. And so I've had some patients that were adamantly against the concept of ganja, but they eat a 10 milligram gummy an hour before they need to go to sleep. They sleep 8 hours and wake up feeling awesome sauce. And so my point here is there's a lot of reasons why I think it's a good discussion. It's not for everyone, but I have found medical cannabis to be helpful in certain situations with my patients.
I'm against it. I'm only against it because, a lot of people are smoking as in a reason for saying that they're doing it medically, but then they are being unresponsible and getting out on the road and driving.
So that's worth talking about. First of all, I don't want you to take a carbon-based life form and light it on fire and suck in smoke. That's not a good idea, right? That's true with tobacco, that's true with cannabis. Now, that's not a good idea because, not just because of what it does to your lungs, but what it does to your immune system. It's very pro-inflammatory. And so smoking stuff can kick up your immune response. That's bad for you if you have MS, right? So if you're going to consume, I'm recommending to my patients to consider edibles, in a tincture. Those are things that I like that are not pro-inflammatory to your lungs and to your bloodstream. Also, you have to be a responsible human. So it's not a good idea to take a bunch of new baclofen at a brand new dose you've never taken and jump in your car and try to drive your kids to school. It's also not a good idea to drink a bunch of alcohol after dinner and then drive home. It's also not a good idea to use medical marijuana for spasticity and then drive irresponsibly. And so you're right. And I've had a couple patients where I had to stop their card because they were using it inappropriately. So it's not a panacea, but I have found some areas where I really think it does good.
That's right. And for the doctor saying about, sleeping better, yeah, great. Take it, go to sleep. All right? Or if you want to reduce your pain so that way you can actually sleep. I mean, a lot of us can't sleep because we have spasticity. Yep. We get middle of the night pain in our legs. Wakes you up, you're screaming. You can't figure out how to get rid of that pain, right? I don't know if any of you go through it, but I do. Anyway, so yeah, it would be great for that. But I'm still, concerned about even taking the edible. How do I know when I've taken too much?
So it involves, actually that's a good question. It involves a lot of experimentation. So when I send patients to a dispensary, I don't just say, hey, have fun. We talk and we plan out some stuff. And if we're going to use an edible, for example, I recommend the following. First of all, edibles come in 10 milligram units. I want you to cut it in half. We're going to start with 5 milligrams, which might be too much. And I don't want you to wake up Saturday, sit down, take it, and then stand and wait and see what happens. Because you're not going to have a very good experience. What I want you to do is I want you to take it right before your nighttime routine when you're winding down. And I need you to pay attention to when does it kick in and when does it wear off, right? I need to know those factors. If you do try to do it, say Saturday morning when you don't have anything that you need to do because you're experimenting, trying to figure this out, you take it Saturday morning, and I want you to write down, I start to feel an effect about 45 minutes in. It seemed to go away by 3 hours. And then afterwards I felt okay. I need to know those time points, and if you can teach me those time points, I can help you dose it like a pill. But it takes some experimentation. And I always want you to start way lower than what you need, because you can't hurt yourself taking too much cannabis, but you can have a really, really bad day. By the way, if you ever have bad side effects, it's a dosing issue. Take a nap. When you wake up, it'll be better.
Great, thank you. So we're out of questions, online, in-house, and whatever. And I just want to say, I'm glad that you all came to listen to this guy who's been a friend of mine for a long time. And we look forward to doing so many other things together going into 2022. In fact, we still have, thank you, Dr. Boster. In fact, we still have a few programs left that we're doing this year, virtually, online, and even one in Lakeland, Florida, where we will be live again next Saturday. But still, this week we have 2 live virtual programs. The following week we have 2 live virtual programs. They are live. I mean, the people living that are doing it, right? And so we do have those 4 virtuals plus the in-house, which may or may not be a hybrid program. And then we also have, at the end of the month, on the 27th, we have a yoga night. So we have been doing yoga classes once a month since June. We have been doing Pilates classes once a month since June. We've been doing physical therapy classes online for the last 2 years now. And we do those programs all on Mondays, and we call Mondays Wellness Mondays for MS. So if any of you want to get into it, just get on there and, see what's going on, okay? Then going forward into next year, we're going to be back on the road again. We do our Compass to Care programs, which today's program really is called as well. And we'll be doing that at least 13 times next year, live, hybrid, whatever, in various portions of the United States. When I say various portions, because MS Views the News excels more than any other patient advocacy organization on doing programs in true rural America. And rural America is where we need to bring our programs to again, so that way people have access to the information that's available. You guys are lucky. You live in a semi-large metropolitan area. You have a lot of different speakers. You have a lot of different MS doctors, and that's great for you all. But when we get out to these other areas, sometimes it's 3 hours away for somebody to drive and be near an MS doctor or longer. Okay, and so we bring our programs to rural America, so that way we could have good doctors go to these places, or nurse practitioners, and we bring all that educational information to those areas. So MS Views the News will be doing that again in 2022. Hopefully, we'll be able to get back on the road more than 13 times, but right now it's 13 in the different states. So I just want you guys to be part of it. Be online, see what we're doing. Go to our website, in the center column of the website's changing, but right now there's a center column. And every month you could see what events we're doing during that month, and you could get online, just register for the different programs and be part of it. Again, it's not just for you. What if you know somebody with MS, or a family member or friend wants to know what's going on with you? Well, if you get online, you can learn from these things. You could share the information with others. Okay, so I'm going to say that's it for right now for this program, okay? I do want to thank everybody that's here. I do want to thank everybody that's online. I look greatly forward to doing this further and more so and more so and more so. And until I can't, that'll be the way. We forgot to ask you a question. Doctor, the lady in the back had a question about brain donation. I try to tell her it only works when they're dead, though. Okay, doctor's coming up to answer that really quick, all right? You got to run. Come on, we're almost out of time. Oh, yeah, you got to get your mic back, too. So, all right. So I totally forgot. So I'm sorry, home audience. We have this one more thing to ask, and I thought it was very important, which is why it really dawned on me to say it again, okay?
Sure.
Brain donations.
Mic's on? Yeah. So MS is a disease that affects the brain and spinal cord. So to learn about a disease, doctors like to look at those tissues. Except we don't look at them very easily while you're using them. And looking at an MRI doesn't teach us, testing 1, 2, 3, 4, Mary had a little lamb, over. Wait, Bill taught me to do this. So MS is a disease that affects the brain and spinal cord. And when doctors are trying to learn about a disease, we want to see the tissue. MRI is inadequate. We can't learn enough from an MRI. And so studying the brain of someone who passed away and donated their brain so that we could learn is arguably one of the most profound gifts that you could ever give a future generation with MS. It's a really, really big deal. And people impacted by MS who donate their brains are becoming less and less frequent. Less and less people are asking to do that. And it's actually a problem. And so if you are inclined to consider brain donation, what a beautiful gift. Now, hold on to it until you don't need it anymore. But the point, I want to make an important point. It's inadequate to identify a university that will agree to take your brain. It's inadequate to set up some legal documents to say that's going to happen. Because when you die, you can't tell them, wait, you're supposed to take me to the hospital within 6 hours to take my brain out, or it's not useful. Your family has to agree to that plan, and they have to be the ones to execute because you're dead. So it's inadequate for you to identify that you want to do it. You need to sit down with your family and say, listen, when I expire, the first thing you do is call this number so they can send an ambulance here to get me because they have to take my brain out and put it on ice so that I can help a future generation. And if you don't have that conversation ahead of time, it makes it really, really hard. I want to give a shout out to a friend of mine at Yale University, a guy named David Pitt. So David and I used to be professors together a long time ago when I had hair. And David is an MS pathologist par excellence. He's at Yale. He has one of the largest brain banks in the world of people impacted by MS who donate. He has like 30 or 40 brains. He does absolute cutting edge research. He and my joke is that one day he'll cure MS and he has to remember my name. And in the meantime, I'll take care of the patients. And his life's work surrounds using these brains to create breakthroughs. And so anyone that's willing to consider that, thank you.
All right, so, by the way, his parents told me he lost his hair when he was like 10, so he's known this guy a really long time. Okay, all right. So anyway, I'm not going to get back into all the things and all the wonderful things that we're doing, have been doing. But, you know, we've been coming to Louisville except for 2020. We've been here, we were here for 4 or 5 years prior to 2020. Now we're here now, and we will be back again next year. It is usually in the month of December. I like getting away from the heat and getting up closer to cooler weather, all right? And I'm glad you guys gave it to me this year, but you didn't give me snow. In the past, I've always been here with snow. Come on. That would have been nice, right? All right. Anyway, we're done. And everybody online, I hope to see you all again on, Wednesday night, next week, MS Neuro TV with Megan Weigel. We're going to be speaking about the holistic approach for dealing with stress during the holidays, okay? So we hope you join us. And again, thank you, everybody.